for breast cancer.
You're right. Yeah.
Ladies and gentlemen, you are listening to NIK NIKAM Network, and we are talking about breast cancer. Let's give out your contact information and all this, so that when we come back after this break, we'll continue with the discussion.
Yeah, my practice is with the Texas Oncology Cancer Center in Sugar Land, which is located on 1350 First Colony Boulevard in Sugar Land, and our office number is 281-277-5200.
Ladies and gentlemen, you are listening to NIK NIKAM Network Talk Show. I am Dr. NIK NIKAM, and my special guest is Dr. Arvind Bhandari. He is an oncologist. We are talking about breast cancer awareness. Okay, let's switch gears and talk about symptoms. Initially we said when the tumor is real small, nobody may know what is going on. And what kind of symptoms do these people present with?
Yeah, the most obvious symptom is a palpable lump.
Yeah.
And other than that, the other symptoms can be abnormal discharge from the nipple, sometimes just a retraction of the nipple. So if a woman notices a change in if the nipple is retracted or is getting pulled in, it could be a sign of breast cancer.
I see. When should a young lady or a middle-aged woman seek help to see if they have any evidence of breast cancer or any predisposition for breast cancer?
Yeah, I think all women should be aware of the risk of breast cancer, and they should go for the screening of breast cancer. For an average woman who does not have any other risk factors, they should start getting the mammograms at the age of 40. There is some difference of opinion whether it should be 40 or whether
heart risk factor evaluation.
Whether
40 years.
40 years or whether it is 50, but I think most doctors and most of the associations would recommend starting the mammograms at the age of 40.
Yeah.
And it should be done once a year. And the main thing is that you want to pick up the breast cancer before it causes any symptoms.
I see, yeah.
So the advantage of the mammogram is that you can pick up some changes on the breast tissue that may not be causing symptoms, and then get a biopsy, make a diagnosis, and then start the early treatment. Because in the early stages, it is curable.
Okay, let's talk about mass screening for women, like in the early 40s or something, who are totally asymptomatic. Because this question came up when I was doing my master's in healthcare. Is it cost effective to do mass screening for women to look for breast cancer or any type of cancer if the incidence is, of course, here is 8%?
Yeah, I think right now what we are recommending or what is being done is like mass screening. It's not on any selected group of women. All women, all women at the age of 40, they should start getting the mammogram, because this is a disease which incidence increases with age. So you start at 40, and then as the women get older, their risk actually increases. So it is a mass screening which is recommended. And now the technology of doing the mammogram has improved a lot. The amount of radiation exposure to the patient is a lot less. And the quality of the mammograms is a lot better, so that women should not be afraid about getting the mammograms on a regular basis.
Okay, while we are on the mammogram, how reliable is the mammogram?
Yeah, again, a mammogram is not 100% diagnostic. About 10% of the cases of palpable lump may not be visible on the mammogram. So if somebody has a palpable lump, or even a irregular or induration of the skin of the breast which feels abnormal compared to the other side, they should be examined by the physician. And if there is a definite palpable lump, even in presence of a negative mammogram, they should get a biopsy. And these days, getting a biopsy is very simple. It can be done with a needle, can be done as an outpatient. The diagnosis is made pretty quickly.
That's interesting. Ladies and gentlemen, you are listening to NIK NIKAM Network, and we are talking about breast cancer awareness. And my special guest is Dr. Arvind Bhandari. And let's talk about some of the other diagnostic tests that you do. Let's talk about what are the things you look for when you do the physical examination when in a suspected patient with breast cancer, or they come for just screening.
Yeah, on physical examination, the main thing we're trying to feel is if there is a palpable lump.
I see, yeah.
If there is any discharge from the nipple, if the shape of the nipple is different,
Yeah.
if there's any retraction. We also feel for any skin changes. We try to feel if the lump is fixed to the underlying structures, if the lump is fixed to the overlying skin.
Yeah.
And also, a very important part of the examination is to examine under the arm in the axilla to see if there is any enlargement of the lymph nodes.
What does that signify if the lymph nodes are enlarged?
Because lymph nodes under the arm are one of the first places where the cancer of the breast spreads to.
Spreading, I see.
So if it has spread to the lymph nodes, the treatment options become different.
I see. Oh, that makes sense. Yeah. What about these other tests? You talk about MRI, CT scan, PET scan. When do you use all these different modalities?
Yeah, MRI of the breast is a definite improvement over the mammogram, but the only thing is it cannot be used in mass screening.
I see, yeah, yeah.
So right now the recommendations for getting MRI of the breast are limited to a certain subset of population who are at the highest risk.
I see, yeah.
And especially that would be possible in patients with hereditary risk.
I see, yeah.
Patients who have the positive testing for BRCA1 or BRCA2, patients who have very strong family history of breast cancer, those are the patients, they should get screening with MRI of the breast. And in those patients, the screening should start at a much earlier age.
Yeah.
There is recommended that the screening should start at the age of 30
I see.
instead of 40.
Those are with hereditary and genetic predisposition for breast cancer.
So I just want to let to let people.
I mean, like Angelina Jolie, she was only 39 years old when she had all this radical bilateral mastectomy and oophorectomy and everything, including with those.
Yeah. So I just want to let everybody know that majority of the patients do not need to consider that kind of option.
Yeah.
And the percentage of patients who have that genetic abnormality is very small. It's maybe 5 to 10%.
I see.
And so other 90 to 95% of the patients do not need to worry about it. Most of the patients don't even need to be screened for it unless they felt to be very high risk.
So when would we use like a CT scan or a PET scan?
Yeah, CT scan we use mainly for staging of the breast cancer. Once a diagnosis has been made and we want to see where else it has spread, then we'll use a CT scan of the chest to see if it is spread to the lungs, CT scan of the abdomen if it has gone to the liver or...
I see, yeah.
And PET scan does help us in borderline cases where there's some questionable changes on the CAT scan and we're not sure if it is due to metastasis or not, then we'll do a PET scan. And these days we're actually doing in our clinic PET CT scan.
Where
this PET scan is superimposed on the CAT scan. So it's any abnormality that is seen on the CAT scan, and then you see if it shows as a hot spot on the PET scan, then you know there is something to worry about.
I see.
But if it's cold spot on the PET scan, then you think it could be something like scar tissue or something benign.
That's interesting. Ladies and gentlemen, you're listening to NIK NIKAM Network Talk Show. I am Dr. NIK NIKAM, and my special guest is Dr. Arvind Bhandari. We are talking about breast cancer awareness, early detection, and treatment. I'm sorry I haven't given the phone number. If you'd like to join in the conversation or if you have any questions, so you can reach us at 281-745-4161. Again, our number is 281-745-4161. And we are talking about breast cancer. So once you detect something inside the breast, the next step is biopsy. Am I right, or am I
Yes.
jumping the gun here?
No, I think once there is something abnormal found on the mammogram,
Yeah.
or if there's something abnormal found on physical examination, excuse me, the next step is
Yeah.
a biopsy. And the different ways to do a biopsy. One simple way is with a needle biopsy,
yeah.
or they call stereotactic biopsy of
I see.
which is done by the invasive radiologist, and can be done as an outpatient.
I see, yeah.
In some cases where the CT guided biopsy or
Yeah.
ultrasound guided biopsy is not diagnostic, then we may need a surgeon to do a
I see.
excision biopsy where
I
they
see.
remove the whole lump
Oh, I see. They
and
take out-
then send it for testing.
So that means when the surgeon goes to remove the whole lump, are they prepared to do whatever is necessary in case there is a spread of this cancer to the lymph nodes, something like that?
No, usually not at the same
I see.
time.
I
The
see, yeah.
diagnostic biopsy is the first step.
To establish the.
The second step is to stage
I see.
where else the tumor has spread, and then third step is the
Yeah.
treatment planning depending on the stage of the cancer.
See, this is kind of familiar to me because I see a lot of female patients with heart disease and all this. And they say, I just went for a mammogram, now I have to go for a biopsy. I said, wait a minute. It's like me saying, chest pain, okay, you're going to need heart surgery.
Yes.
But it is important you have to get a tissue diagnosis.
Definitely, yeah, because without tissue diagnosis, we cannot proceed. That is
I see.
our first starting point.
Yeah.
So we don't make a presumptive diagnosis of cancer based on physical examination
yeah.
or patient symptoms. We got to have tissue diagnosis. And the other thing is the tissue has to be then examined for many other prognostic
see.
factors.
Oh, yeah, I see.
Like
yeah.
if it has estrogen receptors in it, if it has progesterone
Oh, I see.
receptors in it, if it has HER2 new mutations in it, and there are many other newer
I see.
markers that are coming up which will determine as to how aggressive that cancer is, and we can tailor the treatment according to that.
So it would also help you with the treatment plan.
Oh, definitely.
Oh, I see.
Yes.
Ladies and gentlemen, you are listening to NIK NIKAM Network Talk Show. My special guest is Dr. Arvind Bhandari. We are talking about breast cancer. If you'd like to join in the conversation, the number to call here is 281-745-4161. Before we move on to the treatment part, let's give out your contact information and phone number, so in case somebody has any questions.
Yes. Yeah. I'm officed at Texas Oncology Cancer Center in Sugar Land, which is located on 1350 First Colony Boulevard. And our office number is 281-277-5200.
Okay, ladies and gentlemen, if you'd like to join in the conversation, please give us a call at 281-745-4161. Since this topic is so important for us, we're going to just continue talking without any commercial break here, because we want to get all the information that is of vital importance, especially if you say 1 out of 8 women or likely chance of getting a breast cancer. I mean, that's
Yes.
a pretty high number.
Very high.
I
yes.
mean, if you got 10 women in the closed network family,
Yes.
somebody is going to come up with this kind of symptoms.
All right.
Okay, we mentioned talking about a little bit about the biopsy and removing the small lump to make the diagnosis.
Right.
So once you have established a diagnosis, what else you need to do before you go for the treatment?
Yeah, so after the staging workup has done, which included scans, PET scan, etc.
Yeah.
And
Staging is what? Like you determine how far the cancer has spread and
Right.
how aggressive it is?
Right.
I see,
yes.
yeah.
And so presuming the cancer is localized to the breast and there's no sign of
I
any
see.
spread anywhere
Yeah.
else,
That's the best news.
right, that's the best news.
Yeah,
Then women have basically 2 options these days.
I see.
One is because you need to remove the cancer,
Yeah,
and it can be done by 2 types of surgeries.
I see,
One,
yeah.
as was done for many years, is mastectomy,
yeah.
and these days they do modified radical